Hello and welcome to volunteer training for Harmony House volunteers, and this lecture is entitled Communication Principles. My name is Sarah Rossmassler and I'm a nurse practitioner trained in palliative care and hospice, and I'm looking forward to discussing this material with you. I wanted to start with sort of a setting the tone kind of moment here. This is a book that many of you may remember called Tuesdays with Morrie, and it was about a student who's pictured on the right there, whose name is Mitch Albom, who spent time with his ailing professor towards the end of his life. Morrie was dying of ALS, so his mind was intact, and he wrote about this, and it was, kind of a breakout first book for Mitch Albom. So I wanted to just spend a little time thinking about the following, which is an excerpt from the book. Mitch, he continued softly now, you don't understand. I want to tell you about my life. I want to tell you before I can't tell you anymore. His voice dropped to a whisper. I want someone to hear my story. Will you? So I think this is, when we talk about communication, this concept of listening to people in general, but also in particular at the end of life is so crucial. So I hope that kind of gives you the idea of what we're trying to go for here. So today in our lecture, we'd like to first and foremost explore and appreciate the power of communication to both strengthen and build relationships, and to provide really what we're going for is exceptional person-centered end-of-life care. So this is about what's best for the person in our care. Second is to describe principles, best practices, some pitfalls and barriers to excellent communication. What is it that keeps us from doing well, and how can we strive for doing the best we can? Third is to examine some of the tools and guidelines to help foster therapeutic communication in the setting of end-of-life care. And then finally, and this will be sort of sprinkled out throughout, is to invite an examination of our own boundaries. What is it that, where are our boundaries? What are our value systems, beliefs, and sort of perceptions that influence our communication with both residents as well as our colleagues at the Harmony House? So just again, to set the stage and make sure we're all on the same page, reviewing the role and scope of the Harmony House volunteer. Volunteers are surrogate family to residents. There are volunteers who have clinical experience. Some of you may be like me, working in the healthcare system as nurses, aides, social workers, physicians, or nurses. And we are asked to work in the role of the volunteer, not in the role of our professional capacity, but in the role of surrogate family in this situation. And those of you who are volunteers without clinical experience, we are training you to care for residents in the care that they need and that you're equipped to provide. For everyone, Harmony House staff is available for questions and concerns, as well as the Residents Hospice Agency is always available 24/7 for any clinical or psychosocial questions, as well as support for you as a volunteer. And always we want to encourage you to reach out, to not go things alone. If you feel uncomfortable for any reason, that you are reaching out to either Harmony House staff or hospice. So you can see for this one, we're going to talk about goals for communication at end of life. The picture that I've selected here, I thought really brings forth this idea of respect. And as you can see, respect is really a deeply important concept and goal for us when we're communicating at end of life. So first and foremost, we want to be honest and we want to be empathic. And we'll talk a little bit more later in this lecture about what empathy is and how it sort of is on the spectrum of engagement. But first and foremost, we want to be honest. We want to be able to acknowledge feelings of loss and grief in the resident, in their loved ones, friends, family, if there are any, as well as our staff, our colleagues, and ourselves. So being close to dying and death can elicit some strong feelings in ourselves. It can be very profound and magical and beautiful, but also can be triggering and sometimes scary. So the idea is to really try to be in tune with ourselves, our inner selves, as well as our colleagues, and of course, the residents. The ultimate is to convey respect for the dying patient in whatever communication they want or are able to do themselves, but we want to convey respect. And we'll talk about sort of the nuts and bolts of how we do that. And then appreciate the need for information based on a person's personal preference and culture. So, as we all know, different cultures have different expectations, and this is going to come through in how they want to communicate, in what they want communicated to them, and as well as individual idiosyncratic communication styles or desires based on a person within the cultural context. We always want to acknowledge whatever feelings are coming forward as valid, whether or not we think they are appropriate or sort of in proportion to what's happening. Really, the idea is that whatever is happening is valid. And then accepting and promoting respect for the deceased. So some of the principles around communication in general and also at end of life is that words are really important and matter. The words you select should be carefully selected. Language can be very powerful. I've heard story upon story about family members who remember something that somebody has said when their loved one was dying. So either in the context of the resident, what we're saying to them, it may be in certain circumstances the last thing they ever hear. So we want to be really thoughtful and mindful about what the terms are we're using, what our tone is, and what our approach is. So we're just being very careful about how we use our language. Of course, we want to think about resident privacy. So certainly the Harmony House is in the tone and the color of a family home, but there are rooms, and we should be thinking about privacy when possible. So is a particularly sensitive conversation happening in a common space? In the patient's room, is the door open or closed? And of course, asking permission. So thinking about privacy and always bringing control back to the resident. Third is this idea about centering the resident over our own needs. We may come into our volunteer position one particular day and just be maybe a little bit tired or irritable, or even on the other end of the spectrum, we might be kind of bouncy or enthusiastic, and those are natural things that occur. The idea for being cognizant about our communication is to sort of read the tone of the resident and read the tone of the room and the family dynamic, and trying to center our approach on what the tone is of the resident. Wanted to mention about gossip. Gossip is never therapeutic. In either our informal conversations or in front of patients or families or residents, we want to avoid gossip at all times, only discussing what's relevant to providing care. And I think that's an important concept and practice in all clinical settings. A few words about euphemisms. Euphemisms, for many of you may know, a euphemism is sort of a smoothed over or informal way of saying something that might feel a bit triggering for people. And death and dying are some words that we use euphemisms for. So using the term someone passed away or went to heaven. Those are examples of euphemisms that might, in certain circumstances, be positive if it feels like it is too sensitive or too raw to use the words death or dying or even the word dead. So we want to just try to figure out whether using a euphemism is actually clarifying, or sorry, if not using a euphemism is clarifying, or whether, like for instance, if somebody is not if there's some denial going on, and we're not sure if they're really understanding of what's happening, that might be a time to use very clear language and use words like your mother, we expect that she will die in the next couple of days. On the other hand, if it's clear we understand what's the family or the patient understands what's going on, but is not is maybe overly emotional, or it's can look to be distressing, a euphemism may be appropriate in that time. So it's not like it's right or wrong. It's just, again, reading what the situation calls for. So language barriers are important when we're thinking about communication. If possible, we want to use an interpreter. We want to use an interpreter that is ideally not a family member, because that's a lot of burden to put on a family member or a loved one. And those who are hearing or visually impaired, we want to make sure we're making any kind of accommodation we can to ensure that they can understand what's being conveyed to them. So we'll talk more about things to promote understanding in hearing impairment in a little bit. Wanted to mention a few ethical criteria when we're thinking about how to communicate with residents that are approaching the end of life. First and foremost, the information must be accurate. We want to know, we don't want to fudge things or make things up or take guesses. We need to be able to feel confident that what we're conveying is accurate. And this may include the concept of just saying, I don't know the answer to that question, I will get back to you. And that's an important thing to feel confident in your ability to do and know when to do. The words should be understandable to the patient and family. So we want to avoid medical jargon or complex language, complex sentence structure. So getting close eye to eye and making sure that we're using language that is appropriate for what that patient needs at that time. Information should be conveyed in a gentle, respectful, and compassionate manner, and it should be timely and desired by the patient. So making a family meeting or having an important discussion, the timing around it should be centered around when the patient or the resident is most lucid. Sort of, if it's a resident tends to be more awake in the morning, then we should schedule our discussions in the morning. And another consideration is if somebody's had a lot of pain medicine and they get sleepy from that, we want to avoid trying to talk to them at that time. On the other hand, if someone's in a lot of pain or having distressing symptoms, that would again be not a great time to have important conversations. And this concept of being desired by the patient, we don't want to provide information that is not desired. So some people really like to know a lot of information, and other people want to know only highlights or not at all. There may be some cultural influences, but the only way to really know what someone wants is to ask. And so our attempt at trying to figure out what level of information, what time, and whether or not to provide it at all should be driven by the patient or the resident, him or herself. So some best practices. Active listening. I don't know if any of you have heard of active listening. Some of you probably have. Active listening is this idea of really leaning in and listening deeply and thoughtfully to another person. Now, this is in contrast to our typical life where if you think about you go to the grocery store and you run into somebody, you're going to say a few words, they're going to say a few words. It's sort of a banter back and forth. And active listening is really quite different from that. Sometimes we do an exercise where we encourage people to say, talk to their partner, right, for about 3 or 4 minutes and talk just about an experience or even something like, how I make a really excellent cup of coffee. And the other person is assigned to just listen, maybe encouraged with the use of nonverbal, saying mm-hmm, or things like that, but to really listen. And if you try this, it can be very powerful in terms of how it makes the listener feel and how it makes the person who's sharing feel. So I would encourage you to think about that when you're talking to people, whether this is an opportunity to really do some deep and active listening. A few words about silence. Silence is, it can be very therapeutic. You don't always have to answer or acknowledge in a out loud kind of way. Sometimes I'll use silence when somebody's sharing something quite important or scary for them. Is this silence can indicate that there are really no words to respond with, although it doesn't mean that you're not acknowledging, listening, and empathizing with a person. So a lot of that can be conveyed through body language and facial expression, etc. And then asking questions that invite more. So this is not, when you're asking somebody if they'd like a drink of water, but really asking questions that are going to open them up to exploring deeper and more. And this is what Mitch may have done for Maury, is really active listening and asking questions, even as simple as, can you say more about that? Or can you explain that a little more? Those kinds of questions can deepen the conversation and bring it to a more meaningful place, because we are sometimes attuned to I don't want to bother you with my problems, or I don't want to, bore you with my story. And at the end of life, this is a setting where exploring these kinds of things that may bring forth kind of closure or life meaning, it can be very profound. Wanted to mention a few things about closed-ended questions versus open-ended questions. A closed-ended question is something that you can answer with either a yes or no, or in this instance, what would you rate your pain today? You can easily just say, my pain's a 5. And that can be appropriate in some circumstances, but it also, when you're trying to get into that deeper level, you want to focus on open-ended questions. And those might be something like, how are you feeling today? You can't answer that with a yes or no. I mean, you could answer it. One could answer it with, a simple, I'm great today. But that's where you might follow up with a question that invites more. How are you feeling today? What's on your mind? Those are sort of some of the best practices. I mentioned this earlier, nonverbal presence. I wanted to use this picture to sort of illustrate this. If you look at the man as when he's sitting in this chair, he's kind of leaning back. If you look at him and you think, picture him at the bedside, what kind of tone does that set? It looks like he's a bit disengaged. He maybe looks a little bit bored. In comparison to this man who's kind of leaning forward, he looks like he's engaged, he's interested, and that's certainly going to invite more engagement from the resident. We've talked about verbal clarity, which is just being precise with your words, being cognizant of whether you're using euphemisms or not, and of course, avoiding medical jargon. We don't want our patient to look like this, which is, sometimes I'll attend family meetings in the hospital, and I can see on the faces of the patients that they're actually more confused than when we started the meeting. So we want to just go for clarity and simplicity when all possible. Here's a tool that can be used for effective communication. This is called the NURSE tool because you can see that it spells nurse down this left-hand side, NURSE. And the N stands for naming it. And this is where if there's maybe some conflict or some confusion in what you're detecting in someone's stance, you might say something like this. Somebody's gotten upset and you'll say, it sounds like you've been worried about what's going on. That's the idea of naming what's happening. You see a person reacting with a strong emotion and you're going to name what's happening. And that just gets everybody on the same page. The U stands for you understand the core message. If I understand you correctly, you're worried about what to say to your family and how they will react. So this is a chance to not only express that the resident you're listening and that you're seeing what's going on, but also to allow for them to clarify. Actually, you don't have that right. I'm not worried. I'm just feeling sad, and that's fine. If you use this understand the core message technique and they have to correct you, that ultimately is a positive outcome in that now you fully understand what they're saying. R stands for respect or reassurance. I'm really impressed that you continue to be independent, or I'm really, that seems like that was hard and you really worked through it. So that's sort of praising the patient or offering respect and reassurance. S stands for support. This is offering ways to get engaged with whatever they're struggling with. Would you like me to talk to your family about this? Would you like me to, do you want to spend a little more time trying to figure this out? Those are sorts of comments that would be supportive in nature. And then lastly, the E is for explore. This is where this sort of inviting more kind of questions. I noticed you're upset. Can you tell me what you're thinking about? That's a beautiful open-ended question. It's inviting more. It's asking the resident to, open up to a deeper level or further layers. So this is something that some people will actually jot down on an index card and hold with them to try to remind themselves of some of these important communication principles. Cultivating compassion. So this is a spectrum, and you can see in this graphic, this kind of goes from this idea of pity to sympathy to empathy to compassion. And ultimately what we're trying to do is get into this area of compassion. And so let's start here with pity. What is pity? Pity is a kindly, right? It's kind, but can be seen as condescending. And it's sort of aroused by the suffering or ill fortune of another. I sometimes think about this. If I were to see maybe a skinny dog on the street, and I would feel sorry for the dog. I feel pity for it. I'm not going to really do anything about it, but I'm going to pass by and just say like, oh, that's horrible what's happening. So it's not necessarily something that's therapeutic. Sympathy is an emotional reaction of pity towards the misfortune of another, especially those who are perceived as suffering unfairly. We use sympathy, right? When somebody has a family member who dies, you send your, my sympathies. But it's not very active. It's just, I feel sorry for what you're going through. Next up on the engagement ladder is sort of this idea of empathy, which is the concept of sort of walking in somebody else's shoes, the ability to understand and accurately acknowledge the feelings of another, leading to something that's attuned from the observer. The way I picture this is, two people sort of facing each other. One person is upset and the other person has the sense of what they are going through and also feels upset. So it's this mirrored kind of reaction in that you see what they are experiencing and you feel it too. And that's wonderful, right? You want folks to feel that they are being seen. But ultimately what we're trying to go for is this concept of compassion, which is to suffer with. And so it's empathy with an ability, the wish to relieve that uncomfortable or distressing emotion that's happening. So compassion is where we're striving to get to. So I hope that makes sense. This sort of spectrum of pity, sympathy, empathy, and compassion, and really trying to get to a place where I really want to relieve your suffering. Okay, so let's look at we've looked at some best practices, some ethical tenets that we're trying to go for, but we also want to think about what are some of the barriers to effective communication. Hierarchy is always something that we are trying to dismantle. We want to be, we don't want there to be power dynamics or power differentials, inequalities. So we're trying to, and that we can do this in a way where we're not talking, standing over a resident's bed and sort of talking down to them. We want to pull a chair up, get eye to eye, and try to remove those hierarchies, get to a place of more equality, that we are caring for someone. We're not necessarily, having power over them. And this is where we want to give our patients or our residents control whenever possible. If there's conflict on the care team, that can be a real barrier to effective communication. And we'll talk about some strategies to disentangle or de-escalate those kinds of conflicts in the next couple of slides. Rudeness or incivility is something that we will encounter, and we need to sort of know what our own boundaries are and how we're going to cope with any kind of rudeness or incivility. And then when there's stress going on, so something's escalating or something's happening that's more an emergency kind of situation, that's when our communication can start to break down. So we want to always bring forth a level of thoughtfulness, mindfulness, and awareness of what's happening in our own bodies so that we can be as thoughtful in our communication as possible. So let's think about it. When conflict arises, we call these hot moments. And what we typically do in our lives is think about like, well, I was in the right and this person was in the wrong, or this, this person's guilty or this person's innocent. And we, in this situation of end of life care, in our volunteer capacity, we want to move away from like right and wrong and move to what's happening here and what do we share. So in order to do that, we want to think about ourselves. If something gets hot, say there's some rudeness or incivility, somebody insults you, what are you going to do? Hold steady. Try not to get visibly rattled, and if you can, try to provide a holding environment for what's going on. We don't want a situation to continue to escalate or to deteriorate in a place that's going to be traumatic or stressful for either the resident, family, or ourselves. And we're trying to be the ones that are modeling control to bring safety to this space. So how do we do that? Some of the most simple things are really to just take a pause. Use that silence, take a moment and collect yourself. Deep breaths are crucial. And it sounds overly simplistic, but 3 or 5 deep breaths can actually change the situation and change yourself, so that your heart rate comes down, your energy level comes down, and you can return to thinking again. Take some time, step away if you need to, and always, again, silence can be useful in situations like that, and you can be very directive. I can see that the situation is getting charged here. Let's all just take 3 deep breaths. We're going to step away and come back when everybody's feeling a little bit better. Other strategies to try to manage when things get heated or conflict arises is don't personalize remarks. So a situation where somebody's throwing around insults, this is not about you as a person. It's probably displaced anger or fear or worry. And sometimes the care provider can end up being the recipient or the receptacle for a lot of that anger to get placed onto. Try to separate yourself from your role at Harmony House. You are a person, you are deserving of respect and dignity, and we're there in a dimension of trying to provide a holding space, care, dignity for people at the end of life. And then lastly, really know yourself. What are your biases? We all have implicit biases, things that we are triggered by either from our past experiences or from our upbringing or from our current life, our professional roles. What pushes your buttons and what will trigger your own vulnerabilities? So this is where we really want to think deeply about ourselves. And I encourage you to take some time to do that, both while you're in your capacity at Harmony House, but also outside of it. And some people do this through a mindfulness practice of really trying to understand, what is it about me that I need to be careful about? Where are my tender places? Where are the places where I need to be, add a little buffer zone so that I'm protected myself? So thinking about your own experience with dying and death, what experiences have you had in your personal life or your professional life, and what positive things does that bring to you, and what you can offer, and what are some of the tender places that you need to really be protective of? Does a president bring out difficult memories for you? I know for me, when I take care of a patient who is my same age, or has children the age of my children, or somehow reminds me of myself, or something that's dear to me, that can be really difficult. And I might, if I have an awareness of that is happening, I may lean on my colleagues to try to help me, or it might say, this isn't something that I feel like I can do. And that's where your boundaries are really important, and those need to be respected as well. Asking permission to patients to be able to touch them, to share, or to open up difficult discussions. I will say things like that to patients is it okay if I see them getting emotional, and I will say, is it okay if I touch your shoulder? Or is it okay if I hold your hand? So we really want to respect the autonomy of the patient, of their body, of their space. Don't want to be moving things without asking permission. When you're in that dying place and you don't have the ability to, use your muscles or your body to manipulate your environment, it's really important that we as volunteers are helping to give control and reduce that power differential where, we can do whatever we want with our hands and legs, and they maybe have restrictions. So asking permission is a really important concept. Again, being aware of our own boundaries and communicating these, if necessary, to our patients and our colleagues. And then cultivating a consciousness of our own emotional burdens. That's, again, thinking about reflecting back on our own experiences with dying and death. And then not offering opinions without being asked. I use this term like, may I share my thoughts? Or is it okay if I offer an opinion about what we're talking about? And you'll get a yes or no, and that will avoid this idea of offering something that really doesn't land well or isn't what somebody was looking for. Okay, so we're going to move on to challenging scenarios. Say a resident asks you personal questions that you don't feel like you should answer. Are you Christian? Or how many children do you have? Or are your parents alive? I get asked that a lot. And sometimes you feel like you can answer those questions, and that, as long as that's okay with you, I think that's appropriate. But you want to, again, be aware of your own boundaries and know that you can say, actually, I'm not going to answer that question because it's just too personal for me. So thank you for asking, but I'd rather not share. We mentioned earlier some residents with hearing impairments. We want to, if possible, use their hearing aids. This is a picture of something called a pocket talker, which is basically just an amplification device that they put on with headphones, and it just amplifies things that are happening in the room. A resident with cognitive impairment, so someone that may have a very low health literacy, we want to be sure to be using a simple and direct language that they can understand, and then checking back. Do you understand? Can you tell me what we talked about, so that you make sure that whatever important concepts have been prioritized, so that they know we can actually ask them to reflect back what they've heard. The patients sometimes seem to be clinging to life, and there's some work in hospice around giving permission. I'm using permission in quotes, permission to let go. And this is an example of something that you might say to someone who seems to be clinging to life and not able to sort of do that letting go at the end. We will miss you, but we understand it's time for you to go. And that can be really therapeutic, and sometimes can give that final nudge towards the idea of letting go and being allowed to finally die. And then this, sometimes you feel yourself getting emotional, right? I do that. Something's particularly moving and I feel myself welling up or tears coming down my face. And I think, again, there's not a right or wrong answer, but there's an awareness of whether or not your emotion can be therapeutic for the patient or the resident. If you feel yourself getting emotional and you feel like it's just going to be, a sense of empathy towards the patient and not going to take the focus away from the patient or the resident and move it towards you. We don't want everybody sort of leaning over and trying to console you. So you can step away, or you can, just say, I'm feeling emotional, I'm going to step out, and that's fine too. So emotional, either feeling sad or feeling angry, that's a time to just be aware and be able to excuse yourself. And then lastly, there may be residents who have trauma from past interactions with the healthcare system. People who haven't felt heard or felt like they got poor care or misdiagnosis. And there may be, a sense of this traumatic history. So I wanted to just mention that so that you could be on the alert for it. And our strategies for those kinds of situations are to really listen, to let them share their story, that active listening and deep listening, and then convey this principle of non-abandonment, which means, we're going to stay with you. We will continue to take care of you until the very end. So that's important to think through. Communicating with an agitated patient, we want to prioritize communication when the resident is calm. If there are important things to say, we want to share information that may be orienting. I will use, oh, what a beautiful day. It's summer. The sky is blue, and today's Saturday. And to really sort of help ground them into things that they know deeply in their consciousness. Using always a calm, gentle approach, short, clear sentences and directions. And we've talked about hallucinations. Hallucinations can be distressing, or they can be a kind of grounding, actually, towards the end of life. So we want to determine whether the hallucination is affecting the resident in a negative way or is either benign or can be positive. An example of this, a distressing hallucination may be, I feel like there's spiders crawling all over me. Those are things we want to alert ourselves to and treat. And then there may be, on the other hand, somebody who says, they see their grandmother sitting in the chair in the corner of the room. We don't want to correct that. We want to just acknowledge it. And then always thinking about the safety of the resident and the staff as well, in terms of how we communicate and whether or not our presence or our interactions may be more agitating or could be calming. And then this is sort of a wrap up. Who gets these are more broad and profound questions to think about when you're thinking about how to communicate with patients, and our own way of being is who gets heard and why. So we want to make sure that the resident has the ability to communicate, that we're listening to nonverbal as well as verbal communication strategies. We want to think about both the family and the loved ones and each other. So there's lots of different through ways of communication that are happening. So things could be, if we're thoughtful about it, it can be very positive. And if we lose sight of sort of the key messages, that's when conflict can arise. And it's not saying that that's necessarily unavoidable, but when it does happen, we have strategies to try to mitigate it. So to summarize, some of the important points I hope you take away: knowing your own boundaries, triggers, and limits, using some of these ethical guidelines that I've provided, best practices, and the really crucial principle of respect and resident centeredness, or patient centeredness. Aiming for compassion, which is that awareness of suffering and coupled with a desire to relieve it, and then to actively detect and remedy barriers to clear and respectful communication. And when and if conflict arises, settle yourself, take those 3 deep breaths, 5 deep breaths, put a pause on the situation, and then rationally and stepwise de-escalate the situation. So I hope that was helpful. Thank you again for your service for the Harmony House and the residents. And I look forward to meeting you and seeing you at the Harmony House.